View of keratoglobus and its clinical implications. As what is keratoglobus? Keratoglobus is a globular protrusion of the cornea associated with diffuse limbus to limbus thinning. It is degenerative, non-inflammatory, and it can be non to minimally progressive condition. The thinning is maximal at the periphery. The corneal topography shows irregular astigmatism or may show a peripheral arc of increased steepening resulting in flattening or arcing of the bow tie configuration. Histological features described for keratoglobus are frequent disruptions or absence of Bowman's layer, stromal thinning, and disorganization. It needs to be differentiated from diophthalmos in pediatric cases wherein the corneal diameter is increased and the cornea is cloudy. In adults, it might have to be differentiated from megalocornea, where the corneal diameter is increased. The picture taken is from a case report discussed subsequently. Our first case is of a 35-year-old male who presented to us a status post left eye corneal tear repair with vitrectomy done a month ago, with subsequent RD surgery done elsewhere. His vision at presentation to us in that eye was PR inaccurate, while in the right eye, the vision with pinhole was 6/9. He actually had a history of trivial trauma to the left eye, which led to the corneal perforation. His Kmax in the right eye, in the seeing eye, was 74 diopters, and the thinnest pachy was 195, which was located in the mid periphery, as you all can see in the pentacam images. He was advised to undergo a right eye limbal sparing lamellar keratoplasty in the only seeing eye, that is the right eye. A 14 mm limbal sparing lamellar keratoplasty was done. His immediate post-op picture is this. The graph was clear, there was no interface haze, and the vision was 6/18 with pinhole. The final outcome, that is at his last follow-up, that was in 2019, his vision was 6/18 with pinhole. The graph was clear and there was no interface haze. The ASOCT done showed a bed thickness of 353 microns, and there was no interface haze, but there was interface haze, but not involving the central visual axis, because of which he could maintain a vision of 6/9. The second case we have here is that of a 20-year-old male diagnosed case of keratoglobus with a vision of BCVA of finger counting 50 meters in the right eye and 636 in the left eye, with a refraction of -18 with a -3 cylinder. He suffered a blunt injury in the right eye in 2016, following which the eye had to be enucleated. This is his ASOCT picture of the left eye showing diffuse thinning, and this is his pentacam image showing the Kmax as 78 and the thinnest pachy location, which is located in the mid periphery. He underwent surgery in the left eye. 12.5 mm limbus sparing lamellar keratoplasty was done. The immediate post-op vision was 660 going on to 624 with pinhole. In the immediate post-op period, there was interface heme temporally, which resolved subsequently with medical intervention. At the final follow-up, that is 2 years post-op, the graft was clear. There was no interface haze. The vision was maintained to 6/9 with a -3 sphere and a -5 cylinder. And his Kmax, according to the pentacam, was 54 diopters with a pachymetry of 790 microns. The next two cases we have are of two siblings, both diagnosed with both eyes keratoglobus with blue sclera and query Ehlers-Danlos syndrome. On physical examination, they both had signs like hyperextensibility of joints, laxity of skin, etc. They presented for the first time with poor vision due to high refractive error. The first of the sibling was an 8-year-old female child with OU keratoglobus with OU amblyopia. The patient was on regular follow-up, and the refraction, keratometry, and topography was found to be stable on subsequent visits. The patient was advised a limbal sparing keratoplasty, lamellar keratoplasty in the right eye. She underwent surgery in 2014 with good post-operative results. The BCVA was maintained at 612 even at 7 years post-op with a -1 sphere and a -5 cylinder and keratometry of 44 and 50. The younger sibling was a 5-year-old female child with OU, both eyes keratoglobus and both eyes amblyopia. Vision with pediatric charts was found to be 612 in the right eye and 638 in the left eye. The patient was advised to undergo left eye limbal sparing lamellar keratoplasty. But in December 2014, unfortunately, the patient had blunt injury to the right eye with her hand, leading to corneal perforation with vitreous prolapse. She underwent a right eye corneal tear repair. The wound repair site showed presence of leak in the immediate post-operative period. In the immediate post-operative period, in 10 days, and therefore she was taken for a wound revision with a right eye limbal sparing lamellar keratoplasty in the same sitting. Subsequently, the eye had to undergo multiple surgeries on account of multiple complications like lamellar separation and graft failure, secondary glaucoma, etc. Currently, this is a list of the surgeries which she had to undergo in the right eye. Currently, the eye is a status post penetrating keratoplasty with a BCVA of finger counting 50 meters. The left eye was advised a limbal LSLK in 2015. And she underwent the same. Due to the development of interface haze in the post-operative period, she was advised a lamellar keratoplasty. In the later post-op period, interface fluid was also encountered along with the interface vessels for which corneal laser was done. The fluid cleared out, leaving behind a few opacities. This was the immediate post-op ASOCT. This was in 2018 when she developed interface fluid, and this is the most recent ASOCT showing a few opacities in the interface. AGV was also done in the left eye for secondary glaucoma. The vision today is maintained at 624 with a -7 cylinder and a -3 sphere. The last case we have is of a 39-year-old male patient who was a known case. Who came diagnosed as OU ectatic corneal disorder. His vision was 624 in the right eye, 618 in the left eye, with a high cylinder in the right eye, that is -10 and -3.5 cylinder. The left eye was not as much. The keratometry was steeper in the right eye as compared to the left eye. On pentacam, the patient was found to have keratoglobus with a pellucid marginal degeneration in the right eye. Whereas in the left eye, it was only a pellucid marginal degeneration based on the pentacam findings. This is also an ASOCT of the right eye, of the keratoglobus eye. The patient was advised LSLK in December 2015. In the first post-operative month, immediate post-operative period, the graft was clear and there was minimal interface haze. The vision was maintained to 636 and the keratometry Kmax was brought down to 50 diopters and the pachymetry was 912 microns. In 2017, that was his last follow-up. The graft was compact and there was no interface haze and he maintained a good BCVA of 612 with a -4 cylinder and a -4 cylinder, and the Kmax remains stable at 50. This is a summary of the cases.
Yeah, let us just put a pause.
Yes, ma'am.
These are all the cases that you are going to say today, right?
Yes, ma'am.
Okay, you seem to sort of use the word keratoglobus liberally.
Okay, ma'am.
Okay, so can you just elaborate on each cases? What type of keratoglobus? Basically, what are all the types of keratoglobus? Are these patients all the same?
Ma'am, keratoglobus, no, the adult patients which we encountered, They were cases of isolated keratoglobus without any systemic involvement. The two pediatric patients which we had, they were syndromic and they were associated with other conditions. That is, they were suspected Ehlers-Danlos syndrome, so it can be found with associated with systemic collagen tissue disorders. Um,
Okay. So you mean to say that keratoglobus, which is a corneal thinning, can be either isolated ocular pathology
yes, ma'am.
or it could have systemic associations. Okay. So you say those two siblings had systemic association, correct?
Yes, ma'am. Yes, ma'am.
Okay. So that is correct. I agree. But is that all? Are there any other types of keratoglobus which we have come across?
It can be associated with blue sclera syndrome or Leber's congenital amaurosis. But that
forget
is
about the association, Nivisha.
associations.
No, one second. Forget about the associations.
Okay, ma'am.
Per se, the corneal thinning, the way in which it has happened in all these patients is not the same.
Yes, ma'am.
It has happened in various age groups.
Yes, ma'am.
And each one has a pachymetric map, if you see, has shown different varieties of thinning at different locations.
Yes, ma'am.
Some had thinning at the location of steepening.
Yes,
some had thinning in one area and steepening in the adjacent area. And some of the corneas were thin throughout and steep throughout. So that is the crux which we should understand here. The whole point of the class is also that. Okay. So can you just elaborate us on that if you have understood? Or somebody else can help us. Do you know, Nivisha, is there any difference in all these cases?
Ma'am, they can either be diffuse thinning of the cornea, wherein the pachymetry is low throughout, or it can be developed from something like pellucid marginal degeneration, where it starts off inferiorly localized and then spreads the rest of the areas.
Excellent. So the thinning can be diffuse throughout, in which case it is often congenital, like those siblings.
Yes, ma'am.
Okay. So the total cornea thins down, gradually is thin to start with, and gradually goes thinner and thinner. Biomechanically is a weaker cornea. It is a conjunctival disorder, so other organs and tissues can also be involved. So this is a classic case of the siblings where you had keratoglobus, blue sclera associated with the Ehlers-Danlos syndrome, correct?
Yes, ma'am.
Okay, so the other variety is thinning in particular location. It could either be superior, inferior, central, paracentral, but due to various reasons, it gradually expands to occupy the total
entire globe,
entire extent of the cornea. Okay, so this type of keratoglobus is called, if that is called congenital,
acquired.
This is called acquired. Excellent, Karan. So this is acquired. So the basic classification here is it can be congenital or acquired. It can have isolated corneal pathology, or it could be associated with other systemic conditions. From the cases that we have elicited today, it is evident that congenital is often associated with
other systemic
conditions. Okay. So what is the most dangerous thing in all of these situations when the patient is not attended to on time?
Spontaneous globe ruptures.
Yeah. So many of them have lost their vision.
Yes, ma'am.
Yeah. Now it is a double-edged sword. From one side, if you do not intervene, you lose the eye, and from the other side, the surgical procedure is not easy. It has got complications. There are a lot of back and forth coming on, and interface haze, how much to debulk the existing cornea. There are a lot of issues and gray zones. Things are not very clear as to how to do it, because if it is a small area, you can easily debride. If it is a total cornea which is going to be thin, and you are starting with, say, for example, a PMD which has become a keratoglobus, and in the thinnest location, if it is 550 microns, whether you are going to do limbus to limbus 50 microns. It is quite scary to do that because anytime it's going to rupture, and you definitely do not want to put a limbus to limbus penetrating keratoplasty. These eyes are not going to have a good visual potential. So, as a bargain in that, you are going to leave behind some stromal tissue so as to give some tectonic support, so you can do a tectonic LSLK sort of a thing, in hope that in future, if something has to happen like that happened in that girl Shweta, the girl who had multiple surgeries, you at least have the option of doing a LK, DALK or a PK in future. Okay, so these are not easy conditions to deal with. Okay, I hope that is clear. So the classification, the surgical goal as to why we are doing this. Okay.
Yes, ma'am.
Yeah. Now coming to the summary. Go ahead with the summary.
Yes, ma'am. As ma'am discussed, why do we need to treat keratoglobus? So surgery in keratoglobus is necessary to improve vision in patients with spectacles and contact lens intolerance, and most importantly to prevent impending perforation. The surgical intervention is to be considered for structural restoration of the anterior globe and for visual rehabilitation at the same or at a later date. And a special mention is that repair of corneal tears which happen in keratoglobus is also difficult because of the thinness of the cornea that causes cheese wiring of the sutures and wound instability. That is why it is even more important to make sure that the globe has good support, tectonic support, the cornea. Surgically, the treatment is challenging, and there is no known standard procedure for the management of the condition as it is very rare. Surgical studies, several surgeries broadly categorized into full thickness and lamellar keratoplasty procedures have been proposed. Lamellar procedures with or without modifications that preserve the limbal stem cells include epikeratoplasty, central lamellar keratoplasty with peripheral intralamellar tuck, limbal stem cell sparing lamellar keratoplasty, as what our cases we are done in, and use of a corneoscleral rim over the thin corneal periphery. Full thickness procedures include conventional penetrating keratoplasty, corneoscleroplasty, and a two-step tectonic lamellar keratoplasty followed by secondary PKs. Many case reports have been published citing the different surgical methods for the treatment. We have enlisted a few, broadly classifying them into penetrating keratoplasty, corneoscleroplasty, and epikeratoplasty. Conventional PKs in these patients is difficult owing to the extreme thinness of the cornea in the periphery and the resulting graft-host junction disparity preventing adequate wound closure, causing wound leakage. It is also the site of tectonic instability and can lead to traumatic wound dehiscence. Even if technically successful, the optical results are not good owing to severe irregular astigmatism. Attempts to overcome these problems led to modifications of the procedure. Large limbus to limbus tectonic PKs, that is to avoid the graft-host junction complications, may lead to increase in the risk of graft rejections and failure owing to the vascularity of the limbus and compromise of the trabecular meshwork, leading to secondary glaucoma, as we had seen in one of our previous patients. Though it is no longer recommended as a first option for keratoglobus, eccentric penetrating keratoplasty has been tried by Kodikian in 1998. In one case where there was only a localized area of mid peripheral thinning, so the eccentric graft was centered over the thinnest portion of the cornea in order to maximize the thickness of the recipient bed for suturing. Now coming to each of the methods, I would be describing them in a little bit of detail. Epikeratoplasty for keratoglobus was first described by Cameron et al. In 1998. In an interventional case series done by Javadi et al., 7 eyes of keratoglobus patients underwent epikeratoplasty. The surgery involved using a corneoscleral button 1 mm larger than the corneal diameter as an onlay graft, 360 degrees peritomy was done. The corneal epithelium was scraped. The cornea was then superficially trephined equal to the size of the corneal diameter. Circumferential lamellar dissection up to 2 mm posterior to the limbus was done and to avoid damage to the limbal stem cells. The donor corneal button, which was 1 mm larger, was then stripped of the endothelium and the descemex and laid over the recipient cornea after anterior chamber paracentesis to flatten the globular cornea. The margins of the graft was undermined below the recipient rim and fixed with 24 interrupted sutures. This procedure, however, was difficult in eyes with severe thinning, and a two-staged procedure for subsequent PK would be preferred in such cases. Lamellar keratoplasties have been tried by various researchers to overcome the shortcomings of PKs including a lamellar keratoplasty and intralamellar tucks. In a case report published by Jones and Kirkness in 2001, the trephin of the cornea was trephined immediately central to the limbal arcade, just deep to the Bowman's membrane, and a lamellar dissection was continued 360 degrees peripherally beyond the limbus, leaving the conjunctiva with the limbal stem cells attached. This procedure was similar. It resembles a peritomy procedure. It is that there is a supporting rim of peripheral corneal stroma along with it. The central corneal epithelium was debrided with alcohol, and 14 mm corneoscleral button was prepared by debriding the endothelium and laid over the recipient site. Paracentesis was done to flatten out the globular cornea. The overlay graft has, so in this case, the overlay graft has a dual role. It provides more substance to the cornea, achieving a normal thickness, and also helps to alter the shape of the cornea, making it less ectatic and more normal in profile. Long interrupted nylon sutures were used to suture the corneoscleral button. The long bites need to be taken because of the high tension in the suture and need to prevent the suture from cutting through the thin sclera. Once the graft is in position, the donor epithelium was debrided to allow the host epithelial cells to grow over it, and compression pad was applied and topicals were started. 6 months later, at the secondary stage, a lamellar graft, the secondary stage, PK was performed because of lamellar graft and interface haze, and the host graft was folded and distorted. So that is why PK needed to be performed, was performed with a 7.5 mm and 8 mm PK. The patient showed a good visual acuity of 260 at the end of 3 years. The next report was that of Jared et al. In that there was he described a limbal stem cell sparing corneoscleroplasty with peripheral intralamellar tucks. In that, a 360 degrees incision was made with a 200 micron depth using a diamond knife, 1 mm inside the limbus. And like before, lamellar dissection under the limbus was made. The central cornea was trephined with an 8 mm trephine to get through a full thickness cut. The margins of a donor tissue were trimmed circumferentially to fit into the pocket made by the trephine, peripheral lamellar dissection. The endothelium of the central 8 mm donor graft was peeled off, and the graft was tucked into the host pocket and sutured by using modified suturing technique as described by them. The dissected host limbal tissue was also repositioned and sutured over the corneoscleral graft using nylon sutures. An air bubble was injected into the anterior chamber to enhance the adhesion of the posterior flap of the host pocket to the graft tissue. In the next study case report, Vajpayee et al. Performed a central lamellar keratoplasty with a peripheral intralamellar tucks in a Keratoglobus patient in 2002. It was a combination of inlay and onlay lamellar keratoplasty. Dissection of the recipient cornea was performed to avoid increasing the central corneal thickness post-operatively. Creation of the peripheral intrastromal pocket was the same as in the previous studies that help preserve the host limbal cells. So overall, this method increased the corneal thickness both centrally and peripherally, thus achieving visual rehabilitation in the single stage. The recent advances in this is a femto laser assisted tuck-in penetrating keratoplasty, wherein femto laser can be used to make the intralamellar grooves and then manually dissected. The femto laser can be used to shape and design the host as well as the graft. And the second recent is the report is that of a novel. There's a pleating technique wherein the excess of the cornea is brought out to maintain a homogeneous topography. So to summarize, as to why we prefer limbal sparing keratoplasty over any other procedures, is that the corneal thickness is increased both centrally and peripherally, thus achieving visual rehabilitation in one stage and also reducing the chances of epithelial rejection, especially and prevents the post-operative complications such as non-healing epithelial defects, etc. Tectonic repair was achieved in all of the cases, thereby reducing the risk of perforation in the event of progressive corneal thinning in all these cases. Indications of limbal sparing lamellar keratoplasties other than keratoglobus is Murray's ulceration, interstitial keratitis, and pellucid marginal degeneration. Basically, any generalized thinning of the cornea, and especially involving the limbus, a limbal sparing keratoplasty is always preferred. Complications of this procedure is epithelial non-healing and persistent epithelial defect due to an iatrogenically compromised limbus. Graft interface opacity caused by epithelial downgrowth or interface vascularization, as we had seen in one of our previous patients. Intrastromal epithelial cyst formation, graft rejection, and infection, which are the same for any keratoplasty. So to summarize, I would like to say that limbal sparing lamellar keratoplasty is a satisfactory single-step technique for restoring both the structural integrity of the cornea and also without compromising the central optical clarity, and also by preserving the limbal stem cells. Thank you, ma'am.
Thanks for all the inputs.